Oh, hello and welcome everybody. My name is Karen Eggleston. I'm director of the Stanford Asia Health Policy Program. Delighted to welcome you to today's webinar. We have a colloquium series this year entitled Technology, Trust, and Healthy Aging. So look at our website for events coming up every month this year, some hosted by our partners at Peking University. And today, the topic focused squarely on trust, that very important aspect of healthcare not always focused on, and how that shapes the clinical encounter in the market, especially in lower income settings. So we're really delighted to have with us Professor Reshmaan Hussam to present her co-authored research on the market for healthcare in low income countries. Dr. Hussam is a professor of business administration at Harvard University, as well as a faculty affiliate of the National Bureau of Economic Research, the Abdul Latif Jameel Poverty Action Lab, and the Bureau for Research and Economic Analysis of Development. Her research explores questions at the intersection of development and behavioral economics, focusing on health, migration, and finance. She earned her PhD in economics from MIT. So welcome everybody again, and especially Reshma, welcome and over to you.
Thank you so much, Karen, for the invitation and the introduction. I just wanted to make two preemptive apologies. One is that I have a bad cough, which may interrupt the talk. The other one is that I have an active toddler nearby, so hopefully he will not interrupt the talk, but just a warning to my audience. Okay, so I am very excited to share this work with you. It has been a long time in the making. It's tentatively titled The Market for Healthcare in Low-Income Countries, and it is co-authored work with Abhijit Banerjee at MIT, Abhijit Chaudhary, who's a practitioner in India, Jishnu Das, Jeff Hammer, and Akash Mopal. Just to set some context, when we typically think about healthcare, at least in developed country contexts, healthcare is provided in very highly regulated settings with considerable insurance. So even when there's a market, it is still highly regulated. There's insurance, there's subsidies, there's very little in the way of fee-for-service that's not mediated through insurance, which means that we actually have very little understanding of how true markets, like open, free, competitive markets for healthcare work in the real world. On the other hand, in many low-income countries like India, healthcare markets have little de facto regulation. We see multiple providers in each market. We see private providers with a whole range of qualifications who are competing against one another. We see very little insurance, particularly for primary care, which is where we're going to be focusing. And so this suggests, and we'll show you some evidence, that prices, quality, and quantity are set in equilibrium. So what do we do in this paper? Well, the first thing I want to share with you is what we've done is amassed from a series of studies run by my co-authors and others, this large data set, a unique database of standardized patients, okay? And we're gonna use standardized patients to provide a detailed description of these markets. For those of you who are not familiar with standardized patients, just think of these as akin to audit studies. They are trained actors who go into these providers' clinics and elicit precisely because they're experiencing it, the quality of care. We're going to use them to measure quality and prices primarily in India, but we're also going to show you some data from China and Kenya. Using that, painting that picture, we're going to set up a puzzle in the market for healthcare in low-income countries, propose a conceptual framework for why the puzzle might exist, and then, hopefully, if we have time, share the results of a field experiment in West Bengal that allows us to test the theoretical predictions. Okay. All right. So briefly, you know, this is a very, very brief literature slide. There's much more than this, but I want us to think conceptually that we want to position this project amid three other topics. The first is a fairly recent literature on how in environments of low trust that can elicit low demand from patients for healthcare provision. The second is a much longer or earlier literature that predicts overtreatment because of the sort of incentives that providers face. Okay, so provider-induced demand for healthcare and overtreatment. And then finally, again, a fairly recent literature that thinks about, rather than overtreatment, simply incorrect treatment, which includes both over and under treatment, which may be due to particular behavioral biases that these healthcare providers face. Now, we see this paper as intervening in some margin of each of these topics. In particular, we want to ask the question, how does patient demand in low trust settings affect the provision of healthcare by the providers? Okay, so it's this bilateral relationship we're interested in. Okay, so let me give you just a very brief sense of the context we are mostly operating in with the India data we will be showing you. So 80% of first contacts or primary care that is sought in India are with fee-for-service private sector providers. Okay, so that's why we think understanding the market for providers is extremely important. The vast majority of these private providers have no medical degree. Only 4% have an MBBS, which is equivalent to the MD in the US. And there are multiple providers per village. Public providers certainly do exist, and we document that they are more qualified. They have to have an MBBS. They also offer free services, but they only have 20% of the market share for a variety of reasons we could go into. But for now, it's just that the facts are that the vast majority of households seek care from these untrained private providers. And this is just to show you that despite a lot of heterogeneity across all the states in India, these patterns remain clear. There are multiple providers per market, and the vast majority of them are these private providers who don't have any training, no official training, no degree. So let me describe to you how we're going to paint a picture of this market. So how do SPs work, these standardized patients in this setting? Well, what we do is that, say, in a given study, in month 1, we're going to send a standardized patient to visit a healthcare provider. And they're going to say something like, "Doctor, I woke up this morning with a crushing chest pain and I was feeling very anxious." And then the patient will answer whatever questions this provider has, complete whatever exams are administered, like taking their blood pressure, checking their heart rate. And then, of course, the provider may recommend a treatment. Now, there's kind of a very long literature that litigates and relitigates this space of standardized patients. I don't want to go into it, but I do want to assure you that the previous studies have demonstrated very, very low detection rates, about 1.8%. I believe it's around 2%. In other words, only 2% of providers who are visited by standardized patients actually believe that somebody who was not a real patient visited them. And provider behavior is consistent with believing the SP. In other words, providers don't come to the conclusion that an SP is faking it. In fact, the more they do with the patient, the more convinced they are that the SP is actually a real patient that has the condition they're presenting with. Okay, so what happens after the end of that interaction? The SP leaves the office and then records every moment of that interaction. Okay, so that's where we get all the data on how long a provider spent with the patient, what questions were asked, what tests were done, and what treatments were administered, and for what price. So that happens, say, in month 1. Now, several months later, after we complete all of these cases across all the providers, we're going to have 2 enumerators visit this same provider and complete a test of knowledge. And this is how we do it. We have one surveyor say, "I'm the surveyor, surveyor 1. I tell the provider, surveyor 2 will now act as a patient who has come to you. You should try and behave exactly as you would with a real patient." Surveyor 2 says that exact same thing. "Doctor, I woke up this morning with a crushing chest pain. I was feeling very anxious." And then the provider goes through whatever they might go through in theory with a real patient. Okay, so we record all of that. And then we're going to compare this performance of what they actually do with the standardized patient to what they say they would do in these medical vignettes. Okay, this table with a lot of information is just to show you that the data I'm going to be presenting comes from a very large range of spaces, rural and urban, private, but we will also show you data from public sites. For example, China is all public providers, but they, in fact, are not regulated in many ways, and so they behave in many ways similar to these private providers, and across multiple cases, right? So asthma, diarrhea, TB1, TB2, 3, and 4. Okay, just a little bit more on taxonomy before I show you some numbers. I want to define how we're going to think about treatment. Okay, so call the correct treatment vector A. Okay, so for example, for angina, the correct treatment vector A would be take aspirin and get an ECG. All right, so we're going to define correct treatment in kind of the most generous way. We're going to define correct treatment as a patient receiving at least one element of A and nothing else. For example, get an ECG. That's defined as correct treatment. Over-treatment is going to be that the patient receives A, but also B. So get an ECG and buy some antibiotics. And, incorrect treatment is going to be that a patient receives no element of A, they could still receive B. Okay, it can be a huge range from you need an X-ray and here's some antibiotics to buy some pain medication. Okay, that's what we call incorrect treatment. So let me show you what we seem to find from our wide array of samples and standardized patients. Across all study sites, standardized patients are incorrectly treated in the majority of visits. So as you see here, these are quite large numbers. The lowest is Kenya at about 50% of standardized patients receiving an incorrect treatment, but it goes up as high as about 90% in Delhi. Okay, so that's fact number one, which in a literature that really emphasizes the space and the opportunity for over-treatment, to us is quite striking. This is not about over-treatment. It seems to really be about incorrect treatment. So what are the financial implications? So again, just a little bit of taxonomy. What we're going to do is, in this example where A is correct and B is not, we're going to assume that if you only get A, the full cost of a visit is necessary. If you get A and B, the marginal cost of B is avoidable. And if no element of A is given, the full cost of the visit is avoidable. Okay, that's how we're going to price it. These are the assumptions we make, and they're indeed assumptions. You could make other decisions on this margin. Note that this is an ex post calculation. So it could be either a lower bound or an upper bound. It's an upper bound if, for example, doctors learn, right? So they might give an incorrect treatment on the first visit, but then they update and are better able to prescribe the right treatment in the second visit. We're not considering learning. However, it's very much a lower bound if you factor in all the potential health costs that might occur because you're getting an incorrect treatment, okay? And let me just skip that for time's sake. All right, so let me give you some numbers on the financial implications. So here you see that the fraction of the total cost in each of these SP interactions that is avoidable is enormous, once again. The highest is China with 91%. The lowest is Madhya Pradesh in India with about 70%. And on top of that, this is largely not due to overtreatment, but rather incorrect treatment. The bulk of the avoidable costs come from providers simply giving you the wrong thing, not additional things, simply the wrong thing. And here, all I wanted to show you is that this is the case also for qualified providers, okay? So I just highlighted in gray the qualified providers. While the percentages are slightly less, they're still quite high, even if you're qualified, meaning even if you should know better what to do, all right? Okay, so that suggests, that's kind of our first hint that this incorrect treatment that we're documenting is not due to knowledge, not due to lack of knowledge, but let's dig deeper into this question, okay? So we are able, as I described in how we collect the data, to directly measure knowledge using these medical vignettes. All right, so I'm going to show you two objects on the knowledge front. The first is going to be simply comparing your average performance or your average ability to give correct treatment with ESP, so how much you do, and then the average in your vignettes, right? So how much you know on average across all these cases, or whatever it is that we administer for that particular study. The second object I want to give you is the more policy relevant one, which is that the conditional one, right? How much do you do conditional on what you know about that particular case, okay? All right, so let me show you those. First, the absolute no-do gap. Here you see in dark blue is what you know, and in light blue is what you do. There is a large gap across all of the samples in which we measure both of these things. This is true even when you disaggregate by public, private, untrained, and private trained, okay? So again, it doesn't seem to be that people who know more are really doing much more, okay? The no-do gap seems to really be sustained. Now let me show you the conditional no-do gap. So here, let me highlight an example. So let's look at Madhya Pradesh. So in Madhya Pradesh, 70% of individuals can administer in the vignettes any correct treatment. Of that 70%, you see the 23.5% who are actually doing that with the standardized patients, okay? But the other thing that becomes quite obvious here is that there's measurement error. In other words, there are all these individuals, or not all, there's a fair number of providers who don't seem to know what to do, but then end up doing the right thing. That would be 6.7% in Madhya Pradesh, okay? So that suggests that there may be a measurement problem which will lead to us overestimating the no-do gap. In particular, let me describe exactly what our challenge is. So the first pass to this estimating this conditional no-do gap is the simple OLS, right? You regress how much you do on how much you know, okay? But here, the theta, right, which is 1 minus theta would be the no-do gap. The theta is going to be attenuated due to measurement error. So theta is going to go down, which means we would overestimate the no-do gap, which is 1 minus theta, right? So this is just both a small point, but a very important point for those of you who are actually engaged in this in the field and want to collect this data. What we encourage is that you collect 2 points of data on your knowledge, on the knowledge of these providers. What you can do with that is that you can instrument your first measure of no with your second measure. And what that will allow you to do is that this particular IV is going to be biased upward for binary variables. So that allows you to put some bounds, right? So the IV is going to be biased upward, the OLS is biased downwards. That allows you to put some bounds on what your measurement error really is. So let me show you an example of that. So in our case, if you just do the naive OLS, you'll find in Madhya Pradesh that the no-do gap is about 90%, right? The theta is 10%, which means the no-do gap is 90%. But if you instrument our second measure of no with your first measure of no, we just take it at 2 points in time, you in fact find that the no-do gap is about 65%, right? So 1 minus 35%. And that's a big adjustment, right? From 90 to 65% is a fairly big adjustment. So that's number one. We think it's important that we do have accurate estimates of these no-do gaps. But the second broader point is that even with this kind of upper bound on the no-do gap, these gaps are still enormous. A 65% no-do gap is still quite large. And these corrections, wherever we do it in all of our samples, the no-do gaps remain quite large. Okay, so let me take stock so far of what we've learned. Number one is that we find that these primary care markets are characterized by enormous amounts of incorrect treatment, which then translate into a large percentage of spending being medically unnecessary. And I just want to remind our audience that this is largely a very, very low income, very poor patient population. And so who is already spending a large fraction of their income on healthcare. So if 70% of what they are spending on healthcare is in fact medically unnecessary, that seems like quite a big hit to their well-being. However, despite these things, despite us finding so much incorrect treatment, it doesn't seem to be because doctors don't know what to do. They seem to have fairly high knowledge relative to what they're actually doing in practice. Okay, so perhaps the first explanation that might come to you legitimately is that there's really no return to effort. So doctors know how to do something, but they are not incentivized to put in the effort to actually do it in practice because the market doesn't reward effort. So we can explore that question. So let's do that next. Is effort rewarded on the market? So a little more taxonomy. Let's define 3 aspects of the provider-patient interaction. First, time spent with the patient. This is kind of a proxy for physical effort. Then we have checklist completion. What this is that for each of these cases, there's kind of a standard set of checklist items, a standard set of questions and exams that any provider should be asking in order to determine the appropriate treatment. They're very basic set of questions and exams. We're going to see how many of those questions or exams are actually administered as a proxy for cognitive effort, and then whether or not the provider actually administers the correct treatment. Okay. So this is where we set up the puzzle. What is the puzzle? Well, fact 1 is that, oh, sorry for the misalignment there. Fact 1 is that providers who spend more time complete more checklist items. So that's what you see on the left-hand side. On the x-axis, you see how much time providers are spending with the patient. You see that's monotonically increasing with how many checklist items they engage in. And then as you see on the right-hand side, providers who complete more checklist items are more likely to treat correctly. Okay. Fact 2 is that providers who spend more time or complete more checklist items earn more money. So it seems, at least in the cross section, that there is a clear return to investing higher effort in your patient interactions. Now, interestingly, fact 3A is among those who know the correct treatment. So here you can see, for example, so right now, what I'm plotting right here is just those people who know. Okay, so we've established from the vignettes that they know what the right thing to do. There's still a wide variation in how much they do. So across the patients they're engaging with some people, they do exactly what they know, with some people they don't. Okay, so there's heterogeneity there, both in Birbhum and in Madhya Pradesh. Those are the 2 plots I'm showing you. And those density plots are just showing you that there's providers on all levels of this, right? So it's fairly widely distributed how much providers are actually investing in their effort. Knowledgeable providers are investing in their effort. And fact 4 is those who do more charge their patients more. So again, even conditional on knowing, there's wide variation in how much you do, but when you do more, you also charge your patients more. In both Madhya Pradesh and Birbhum, this wide variation in due is priced in the market. The fees are increasing by 300 to 400% depending on how much you're doing. So it seems, again, that indeed there are high returns to effort. This regression table, the real point is just for you to see that there's a lot of stars and they're all positive. So the main point is simply that kind of no matter how you cut it, for the most part, fees are higher for providers who are spending more time, completing more checklist items, and treating correctly more often. I'm sure you are thinking, well, you're just presenting cross-sectional estimates. These are just correlations. They might be subject to an identification issues, right? I'm not showing you something explicitly causal. In particular, maybe more knowledgeable practitioners do more, right? Their no-do gap isn't 0. And more knowledgeable providers are going to treat better and price higher. They're just those types of people, right? The nice thing is that along with our SP data, several of these data sets, we also have real clinical interactions. So we have a surveyor posted outside of these providers' clinics who actually count the number of actual patients that are going in and do brief surveys with each patient. Okay, so now why don't we look at those real patients? Because if we look at real patients, we can actually include provider fixed effects, okay? And that actually explains half the variation in time spent and actions completed. Half the variation in time spent and actions completed is in fact within provider. So we still have a lot of variation to look at if we impose provider fixed effects. So what do we find there? We basically find that it doesn't matter. Okay, so in other words, we still see these monotonic relationships, even conditional on looking at the same provider, on a single provider across their patients. And this is true for time spent and prices charged. This is true for number of checklist items administered and prices charged. So here, what I'm showing you is the blue, for example, the small dotted lines are no fixed effects. The longer dotted lines are with fixed effects, and they basically lie on top of each other. This is just showing you the regression analog. Even with real patients, we still see returns to effort, even when we impose provider fixed effects, and importantly, even when we control for a patient's health. Okay, so their ADL score is a measure of their health status, which helps us think about whether there's patient sorting. We don't find patient sorting, and in other words, sicker patients are going to certain people than others. Even controlling for the patient health score, we still see these patterns. Maybe your next explanation for this puzzle of why there's such high incorrect treatment is that providers are simply time constrained. They're too busy to ask more questions and reap the financial returns that we've documented they could potentially reap in the market. Do we see this? So here, what I'm plotting is the total amount of time that a provider spends with a patient per day. Okay, this is for Madhya Pradesh and Birbhum, 2 sites in India. And you can see that the average amount of time is about 30 minutes, despite sitting in their clinic for the vast majority of the day, for several hours in the day. And they're not doing anything else. So in these settings, these providers are not faced with a long line of patients and they just have to see patient after patient. No, they're sitting there, they're waiting for patients. Total, they see 30 minutes worth of patients a day in their many-hour workday. Okay, they face enormous excess capacity. So how do we understand provider behavior? The providers are not time constrained. And if we use our regression estimates, we can calibrate about how much additional revenue they could gain from spending more time with each patient. And these calibrations suggest some pretty wild numbers. It's that they can earn an extra 10 cents per minute or $1 per 10 minutes in a world where comparable wage for their skill set would be $3 per day. Okay, so these measures are just too high to possibly explain high incorrect treatment with lack of capacity or lack of returns to effort. Okay, so the economists have failed us, so we're going to turn to the anthropologists for some wisdom now. And so I'm going to just offer some quotes from this really brilliant piece, The Fallen Idol, by Vaibhav Saria in 2017. Corruption in the health sector in Patna was perceived by patients as the prescribing of a diagnostic test and medicines that resulted in cuts for the doctors. To counter this charge, a lot of doctors send their patients for investigation only in the second visit if the complaints of the patient have remained persistent. If I tell the patient straight away that they have to go get tests that cost 10,000 rupees, he will run away and not come back. The poor patients who came to the many clinics in the densely medical landscape of Patna with cough and fever were never tested for TB, but were given medicines that would alleviate their symptoms. This was not because doctors did not understand the severity of the epidemic, which they knew about only too well. They hesitated in initiating investigation because immediate investigation and treatment would, as we have seen, raise suspicions in the minds of patients and make them vulnerable to defaulting. It would prolong their suffering in their hunt for a doctor who they felt was not corrupt. The clinical encounter was not just an exhibition of power on the part of the doctor and of resistance on the part of the patient. Rather, corruption made them both vulnerable in different ways. Trust enabled patients to bear symptoms or side effects within a narrative of healing rather than a narrative of corruption. Okay, so this is where we are now going to entertain this idea that the missing link is that providers will respond to patients in particular ways in environments of mistrust. And that's because the provider-patient relationship is a bilateral one, right? It's not one in which the patient provider gives and the patient takes, but it really is an exchange. What this implies, if this is indeed true, is that a positive shock to patient beliefs of provider quality should enable higher quality providers to, in fact, close their no-do gap. Because if a patient believes that you're high quality, then you should actually be able to engage in the things you know and do them because the patient will reward you for them. They'll actually pay you for it, or they'll come back, etc. Okay, so let me bring this into a simple conceptual framework that can help deliver some testable predictions. Now, let's first consider the demand side, right? The patient side. A patient, think of a patient as having either a serious condition like pneumonia or heart attack with some probability P, or a mild condition like cold or a flu with probably 1 minus P. And if they're not cured, they're going to suffer more. They're going to bear a higher cost for the serious condition than the mild condition. So far, quite standard. And what a patient can do, what their choice is between doctors, right? Recall that there are multiple doctors per village. There's this market of doctors, and you choose your doctor with one thing in your mind, which is that you have some prior that a doctor is of high quality. Now, what's happening on the supply side or the doctor side? Well, a doctor can be either of high quality or low quality. And every doctor can choose to invest either a lot of effort, like a lot of time spent, a lot of questions asked, or very little effort. And that's going to have corresponding probabilities of being able to cure all illnesses or only the mild one, okay? And that probability is a function of the doctor type and the illness type, right? Now, importantly, the key assumption here is that the cost of effort doesn't vary by doctor type, okay? Only the usefulness of effort. In other words, the cost of investing 2 minutes or asking X, Y, and Z questions is the same whether you're a low type or a high type. The only thing that's different is how much that asking of questions actually translates into a cure for the patient. In other words, a low type can mimic a high type in the things that a patient can see, which is time invested and questions asked. Okay, so the doctor and the patient are going to contract over the amount of effort that's invested, which is the only thing the patient can observe, and the fee that's paid. Okay, patient is willing to pay X amount, or a doctor's willing to accept X amount for this amount of effort. Importantly, you can't contract over the outcome of the treatment, right? You can't contract over whether the patient is cured or not. This is like kind of a spot contract. You're just giving the money at the moment in which you are treated. So if that's the case, what are the incentives for quality? Well, a patient can decide not to come back if she's not cured. Okay, so we're going to set this up in a 2-period model. And let's just kind of briefly mentally walk through what might happen. Okay, so let's start in the second period. The game ends after the second period. So if you're in the second period, because patients cannot contract on the outcome, right, whether or not they're cured, L types in the second period, low quality doctors always have an incentive to pretend to be high quality doctors, right? They always have an incentive to mimic high quality doctors and how much effort and time they're putting in, because the patient's not going to be able to pay you based on the cure, but only pay you based on how much you are putting in, which means there can be no separating equilibrium in the last period, in the second period. Okay, how about the first period? Consider that there is a separating equilibrium in the first period. This means that providers are essentially truthful about type, right? You're separated, you know who is a high type provider, you know who's a low type provider. If that's the case, then patients won't base their return in the second period on the cure, but simply on the type, right? Because what they really care about is going to a high type provider. But if that's the case, then low types always have an incentive to deviate because the outcome is in fact irrelevant because it's a separating equilibrium. Okay, which means that a separating equilibrium is not sustainable. Pure separation in this setting is unstable because there's no way to impose a cost on a low type for deviating. What are the implications of this setup? Well, the first two are things that I have shown you. We've documented from the studies I've shown you so far. Number one is because effort is contractible, we should see that positive relationship between effort and fees. Okay. Number two is that because you have this pooling equilibrium or only partially separating equilibrium, there will always exist this no-do gap across the majority of provider and patient interactions. Because the high type providers, they're falling into this pooling equilibrium with low type providers, they have no incentive to engage in more effort because the patient can't tell between the two and is unwilling to pay or reward a high type provider for being high type. Okay. Now, the new two components that we hope to give you new evidence for, beyond what we've already shown you, is consider an intervention that exogenously positively shifts patient beliefs about the abilities of a provider. What might this do? Let me just skip to the second possibility. What this might do is create greater separation with a greater fraction of high types, high quality doctors enabled to invest in high effort because now the patient believes that you're actually a higher type and the patient is willing and trusting, willing to pay you or reward you for your high effort. Okay. And finally, what this setup implies is that a change in beliefs, if all that happens is a change in beliefs of patients about providers, it implies that the provider is simply going to move along their production function that relates effort to quality, right? It's not that they are reinventing themselves. It's not that they are becoming better. It's not that they're shifting their own quality. So there's no shift in the function itself. It's simply that they're now enabled to move along it to a higher level of effort and a higher level of quality and also a higher level of fees. Okay. So in my last few minutes, let me share a setting in which we think we can offer some suggestive evidence that this is indeed what's happening. So we're going to pull from an experiment that we ran in West Bengal about 10 years ago. The first paper on this was published in 2016. And what this experiment was is that we identified a group of informal, so these are private, untrained providers in Birbhum, West Bengal. And they were given 9 months, and then we randomly selected a subset, half of them, to receive 9 months of training. Okay, this training was quite intensive, 4 hours per session over 52 training sessions. Attendance was fairly good, 54%. And most importantly, this training seemed to be a very credible signal of quality. The organization that was administering it was very well known, quite reputable throughout this whole area. A lot of the households of the patients who these providers served knew of this organization. Those patients also knew that these providers had to shut down their clinic about once a week or twice a week to go to this training session. So it was quite costly for the providers in terms of time, transport, and also lost income to go. Okay, so we think of this as a credible signal of quality. Now, that 2016 paper documented that this program increased quality of care, so correct treatment, by quite a bit, by 13%. And what we're going to do today is examine kind of the mediating factors. We examine if the treatment had any effect on the provider knowledge, the no-do gap, and then also that production function of effort to performance, to treatment. Okay, so let me just show you quickly what we found in the 2016 paper. This is just to reiterate that it had quite substantial impacts on the quality of care as measured by SPs, so a 6.7 percentage point increase in the checklist items completed in the SPs, a 12 percentage point increase in correct treatment, et cetera, okay? But surprisingly, given the purported intent of the program, being a training program, we find no impact on knowledge. Okay, this is true neither in levels. So here you see that there's a marginal improvement in the number of checklist items you ask, but no improvement at all, no change at all in how much correct treatment you're administering. Okay, nor do we see any change in knowledge differentially by baseline knowledge. So here you see that, for example, individuals who knew more, so providers who you might think of as higher ability at baseline, are not differentially gaining more in terms of knowledge through this treatment, okay? So there really doesn't seem to be any movement on the knowledge margin. So then the next question is, what happens to the production function? Maybe it's not knowledge explicitly, but maybe it's something in which providers are better able to translate their knowledge into action. They're able to be more efficient. So higher treatment rates and prices could be due to this shift onto a new effort and price production function, right? In other words, you can think it's not direct knowledge, but the thing that I know, I'm now better able to know how to efficiently and quickly manifest that in practice, right? So that would be some sort of shift in the curve. Alternatively, as I mentioned, it could be a movement along the curve. Okay, so there's no change in underlying productivity, but a movement along the curve would imply a shift in demand on the demand side of this market. Okay, this suggests a further test. Quite nice test in a setting where we have a field experiment or we have a counterfactual, right? If the intervention only changed patient beliefs about quality and not underlying quality, we should find that that production function remains the same in control groups and treatment groups, right? The treatment is not going to change the actual shape of the production function. We can compare it to control to see. So do we see this? Well, we see no shift in the curve. We don't see that the mapping of effort as measured by checklist items completed onto correct treatment changes at all, right? Here you see in blue the control groups production function, and in red you see the treatment groups. Same is true for checklist or effort on fees charged. Again, these two lines just lie right on top of each other. So we don't seem to see any evidence that this training program shifted a provider's underlying productivity or, again, knowledge. Instead, what we seem to see is that the treatment enabled high-ability providers to translate their knowledge into action, not becoming more productive, but simply enable the translation of knowledge into action. Again, well, most likely, or the way we're interpreting this is because patient demand increased in this space, because patient trust increased. So the way I want you to read this table is, you see that on the left-hand side, our outcome is what the providers do. And this interaction is showing that it is those individuals who know more, right? Their checklist items completed in their inline vignettes, they're articulating that they know more. They're the ones who are most affected within the treatment group. Okay, so they're the ones who are really manifesting higher performance with the SPs. Which in other words suggests that this intervention led to greater separation between the high types and the low types. Another way we can see this is a simple mediation analysis, in which we find that these improvements in correct treatment are basically entirely mediated by how much effort you're investing in the interaction. Okay, so let me just skip through this for lack of time, but let me just jump to the key takeaways, since I would love to have a broader conversation. So what do we find? We find that across many of these markets, the rates of incorrect treatment are really, really high. And that translates into extremely high levels of avoidable financial costs, okay? But this is not because of lack of knowledge. Providers don't do what they say they might do. And you would need to have extremely high costs of effort to explain this gap with an explanation of low incentives to effort. Instead, what we find more compelling is this theory that relies on a demand side story, right? That a provider's reputation matters in this bilateral interaction between providers and patients. And our a case study from West Bengal offers some suggestive evidence that this might be the case. So what are the implications? Well, even though at first glance, these markets appear to behave well with significant returns to quality, we find that there are significant inefficiencies due to incorrect treatment. And in fact, this is not some new insight. The bilateral consequences of low trust were highlighted by Arrow in 1963 as central to healthcare, in which he articulated that in environments of mistrust, providers may distort how they care for their patients. It's just an insight that has, for the most part, in many ways, been lost over the subsequent decades. And we find that at least in a case where we can actually look at a counterfactual, which is this RCT in West Bengal, these distortions in the healthcare market appear to be large. Okay, so the experimental results from the West Bengal study in Birbhum suggest that a decline, suggest that the intervention led to a decline of 15 percentage points in avoidable medical expenditures due to better treatment. Okay, and I'll just end there. Thanks very much.
Great. Thank you so much. I'll just start with a little bit. So first of all, you pulled together evidence from many different studies and mentioned also some advice about using a standardized patient method. So maybe you could also talk a little bit about what can be learned from comparing across contexts, and if there's a way of measuring and thinking about the policy implications for building trust in different markets. It does seem as successful as the one that it does seem like a high cost way to try to provide training to all the providers and then not actually change knowledge. But, so do you have any thoughts then about building that trust and what are the appropriate interventions and learning across settings, what fits for a given setting? Any thoughts on that?
Yeah, I mean, I would love to hear what others think. We've been struggling with this because, one way to ask the question is, what would be the ideal experiment through which to test this theory, right? So like, if you could build the right experiment that really is able to shift trust and then see if these ensuing things happen, how would you do that? What would be the right intervention? And it's actually quite challenging. So like one thing you might think of doing is making public the quality of providers, right? So like have them all take some exam and then some certification that, look, these are the high quality guys, these are the low quality guys, that will allow patients to then see, like you've basically created the separating equilibrium. In low trust settings, that's a very hard thing to do. Who are you going to trust to do that? If a provider puts up a certificate, you can't trust that that's real or legitimate or not. And so you're right. I think the intervention we have seems like a very costly way to build trust. But at the same time, it seems that you need to have some sort of costly exercise that providers engage in that shows that, hey, look, take me seriously. I'm a high quality guy. Now, maybe it doesn't have to be a whole training program in which you're imparting knowledge, which doesn't seem to actually improve their knowledge, but some sort of high cost on some other margin intervention, I think, is probably the most credible signal of quality and therefore increase in trust between the patient and the provider. But I mean, to be very honest, we've been struggling with that. Like, what would be the ideal intervention? Beyond like kind of deeper changes in norms in the community building efforts that maybe are unique to different cultural contexts. I'm not sure what the right answer is there.
Thank you for those thoughts. We have some questions from Jianan Young, who's one of our partners there in Beijing. Maybe, Jianan, I will just allow you to talk so you can ask your questions in Q&A.
Thank you, Karen. And thanks, Reshna, for this very exciting talk and projects. So I have some like quick clarifying question. First is about your cross-country comparison. So I'm curious, you compare like the results from some SP visits. I wonder whether they're presenting the same condition to the physician. And then like the second one is, I know we are talking about primary care in like low trust and low income settings. So in this setting, how are the physicians get paid? Are they mainly just the owner of the clinic they work for?
Yeah. So on the first question, all of our regressions will have SP fixed effects. And so those fixed effects control for what type of case it is. So we're like comparing across cases, we're controlling for cases basically. And on the second question, sorry, case fixed effects, not SP fixed effects, case fixed effects. So we're looking within cases, the variation within cases, within the same type of case. On the second question, yeah, so it seems that so you should think of like the vast majority of the individuals in the Indian context as these private untrained providers who open their own clinic, run their own clinic, and they get their income is from the consultation fee and the medication fees. But interestingly, even in public settings, for example, in China, this seems to be the case too. Even though providers are paid some nominal stipend by the government, most of their income seems to again be from like kind of under the table consultation fees and medication fees.
Thanks. I think it's important to understand the incentive structure of the physicians in this setting. And I do have like one last question. You talked a bit about like corruption, this concept, and those kind of like codes you put there, I think are like super kind of striking and helpful. But I wonder, like by corruption, it seems that we're talking about like a no-do gap, right? So whether I know and like how much exams or set and satisfied to prescribe to the patients, right? But in the model, it seems to like we refer to the quality as how much they know. Am I understanding it correctly, or can you explain a little bit about that?
I might be misunderstanding the question, but yeah, let me maybe try to clarify how we think of corruption. So, so patients in the quote world, patients don't know whether the reason a doctor is prescribing something is because they really think it's useful or because they're simply doing it to maximize profits, right? And so the parallel of that is in the model world, you have the low quality doctors who could mimic the high quality doctors and just be putting in time or prescribing certain medicines or treatments because they want to reap the benefits, the monetary benefits, and not because they actually think it's useful. So that act of mimicking, of low quality mimicking high quality, would be the act of corruption that patients are worried is happening. Does that
right? Yeah, I think that's clear. Thanks.
Okay.
And thanks, Karen.
Great, thank you. So another question would be, can you talk about, you see this as different? I know you brought together many threads of different literatures, but there is that whole, you referred to Kenneth Arrow, there's a whole market for lemons tradition, right? And the question of, can you trust your plumber, your car repair, et cetera? So what is specific to the market for healthcare, you think? And why is it that credentialing doesn't send a credible signal in these markets, do you think?
I mean, if we had credible credentialing, then I think it would solve the problem, right? That would be the separating equilibrium. The challenge is, how do you gain credible credentialing? And in a world in which patients are in their status quo is that of corruption. So if you were to walk into any of these clinics in rural West Bengal, you would see so many certificates hung on the walls. And these are these small programs that they do here and there in an effort to look legitimate, right? And that sounds like a normative thing. I don't actually mean it that way. You know, they are actually contributing enormously a lot of good to these communities. But you see these efforts to signal their quality, which patients just don't pay attention to. And so I think, to me, that's if we could solve the signaling problem, if we could credibly signal, that would be great. We think of this program as one potential way to credibly signal because it is so costly and because it is from a reputable organization that these patients know. But to me, that's the whole challenge in this setting, to do that. When you start at a base of assuming corruption, or you start at the base of knowing this is a pooled equilibrium, and how do you create that separation? I think the credibility is the challenge. Yeah, I don't know if that answered your question.
Yes, thank you so much. So a final question would be, longer term, in the setting that you did study, don't the low types just end up imitating in the end? Or is that a sustainable equilibrium that shifts the quality for everybody in that market? Do we know going forward the sustainability of that intervention?
I see. Well, so yeah, I didn't go into the details of the model, but there's some cutoff at which it doesn't make sense for the low type to imitate the high type anymore, right? So there's some amount of effort invested that if it is actually if there are returns in the market for that effort invested, if patients believe that, then that doesn't make sense for low types to invest that much. And so when we say that there's a greater separation, you could have greater separation in two ways. So I skipped over the first one, which is precisely this pooling. You could have everyone pooling at a higher equilibrium. Okay, so that's both good and bad. It's good because the high types now get to perform what they know. The low types are now kind of inefficiently investing time and effort, which just might not be smart. Okay, so that's one possibility that I skipped over that one. The other outcome is increased separation, in which the increase in patient trust is so high that these high types really shift on their effort invested and how much they get from it. But low types don't have an incentive to shift that much. It doesn't make sense for them. It would be too costly for them to invest that much effort. And so they remain where they are. And so that's what I meant by increased separation. Empirically, we find that it seems like there's increased separation. But again, there could be a world, as this questioner asked, in which you have pooling at a slightly higher level, which for the most part seems like a good thing, but it could also be bad. It could just be inefficient exertion of effort.
Right. So as the whole market evolves and the government comes in, either with some form of insurance, there are big expansions in India, of course, as elsewhere, then we'll see continuing evolution of the markets, right? So we encourage all the young researchers out there to take the advice here and measure carefully and think about how these markets develop. And thank you so much again, Reshmaan, for sharing this research with all of us. Thank you all for joining the webinar today. And we look forward to continuing to look at this line of research and seeing how it makes a difference for some of the most vulnerable people on our planet. Thank you again so much, Reshmaan.
Great. Thank you all so much. Thanks, Karen.